Good afternoon, sir. Kumar this side. Hello.
Hello, who is this? Is it Saji?
Yes, sir.
Hi, how are you?
I'm good, sir. How are you?
We are the only two faithful people here. Anyway, I'm in Delhi.
Okay, sir. Okay.
I'm speaking from a hotel.
Okay.
Today is our National Neonatology Forum counting today at I think voting ends at 4 o'clock, and so I'll be there till 4:30.
Vinita madam is also joined.
Huh?
Good afternoon, ma'am.
Who has joined?
Vinita madam.
Ah, very good. She is the host for today's meeting.
Yeah.
Compare or whatever you want to call her.
She had called me in the morning. I told
Ah,
I'll be there.
I don't see her.
Good afternoon.
Hi, good afternoon, Dr. Vanita. How are you?
I'm fine, Doc. How are you?
I'm all right.
Yeah, all charged back for NFL election.
I checked in. My worry was if the flight is delayed because there has been a little bit of disruption by hoax bomb calls.
Okay. I thought the weather.
No, hoax bomb calls in the last 2 weeks. There
Okay.
have been more than 25 such calls. Correct, no, Saji?
Yes, sir.
I don't know. I believe all the teenagers are doing it.
Yeah, but I thought India was really strong in filtering such people.
Yeah, that has been done promptly. The
The
last
hoax,
few days, it has not been there.
the guys are taken care of, not to spread the hoax
Yeah,
unnecessarily.
yeah, but at the same time, because of our population, the number of guys to be taken care of is huge.
Yeah, that itself is a burden.
Yeah. I have reminded Kavita. I have
Yeah,
reminded Baswaraj and Yogesh. Yogesh has replied.
I had a word with Dr. Kavita in the morning.
Very good. Very nice.
And
She's prompt. She's prompt.
yeah, and I discussed with Dr. Khadija also. She's presently in the clinic. She will join us. And Dr. George and
Dr. George, yeah.
yeah, I didn't have time to speak to him, but I think he has agreed to.
I think his secretary should.
Yeah, he's agreed to come over for the online only. I'll take a minute to call Joel if he's around so that we can meet him.
Yeah. What I was about to say is, do you want me to introduce you or you will self-introduce yourself and start?
My introduction will be that my name and that I'm a pediatrician.
Designation and hospital. Yeah. And that should be what I also will say. Because we are going to keep it short and sweet.
I will introduce others also with the short introduction.
Just that, their designation and their names.
Yes.
That's all.
Yeah.
A name
so
and
that,
then designation. Yeah.
We don't get lost in long drawn.
Correct. Because people are busy these days.
Because with that also. And I don't know how sensitive they are for, short and long introductions. So let's make it equally short so that nobody gets affected.
You're a
by
very
this.
cautious person.
Not that because I'm not aware, right? So I don't want to touch the raw nerves of anybody. So I'll just call Joel and see if he will join us.
Yeah.
You had your lunch?
I didn't have an elaborate lunch. but I had something to eat. Have we met when we were in India?
Yes, arranged. He's coming over.
There's one question I want to ask, Vanita.
Yes,
Have we met
Doctor.
when you were in India?
I was also wondering. We have taken well enough in our.
The other day I was
Probably we
thinking.
have met. I don't know. I was in Indira Gandhi during that time. I happened to have visited.
That was during which years?
2000, 2001 to.
Maybe.
No?
I came back to India in 1996.
2003, I delivered in that hospital. So Dr. Mala was my obstetrician
Which hospital?
in KR.
Oh, is that right? Then Janaki and me must have been there.
I think so. I don't know in that connection I've met. But I used to come with Dr. Ramesh for some surgical interventions. Dr. Janki used to call him that time. I might have come along with.
Yeah, correct. He was, during those days, you are a pediatric surgeon. And then we had Jayant Iyengar after that.
Really, I don't know Dr. Jayant Iyengar. I know Dr. Ramesh. And after that, lots of things happen, and I happen to be here.
Currently, Jayant Iyengar, currently Ramesh is the senior most pediatric surgeon, if I may say so.
Is
that
it?
time, Jayant Iyengar was the senior most.
Okay, there was Dr. Chandrika also along with him. And he was also in Indira Gandhi those days. After that, she left to Australia, and after that, only Dr. Ramesh used to be there. So that time, probably I've met you. So I have prepared the agenda on the lines that you suggested. So I will introduce this collaboration, and I'll open the floor to Dr. Basavaraj to officially preside over inauguration, and then introduce Dr. George to you all, and then he will have his say, after which I will open the floor to Dr. Yogesh and you, and we will start the event.
And then introduce Kavita.
Yes.
Saji, are you still there?
Yes, sir.
Now, you will get a count of the number of people who have attended, no?
Yes, sir. Yes, sir.
And this is a common platform for everybody, or is there a panel?
Sir.
Yeah, I discussed it with him. He said he would organize that.
I'm going to inform you, sir. Yeah, they're waiting, sir. They joined.
So you have two floors, is it?
Yeah.
Excellent, Saji. So you have become already a specialist in this.
Sir, Basura sir was calling, sir. So sorry, sir. Yeah,
Okay,
sir just called. I said
okay.
we all are there. You are there. Madam is there. So he'll be joining.
Yeah, no, that's okay. You attend to Dr. Basavaraj.
Yeah, it's done, sir. It's done. Yeah, he'll be joining in a minute.
Okay.
So we'll have our first introduction.
Tell Basavaraj about your Indira Gandhi thing, because he's still in Indira Gandhi.
And BMC, I think we may have known each other. I'm not sure.
I don't know whether his MBBS was in BMC.
Might have been. I think MBBS BMC.
Because he's not from Bangalore.
Is it?
Yeah.
Okay.
I'm from St. John's,
Is it? Okay.
one of the very early batches.
Dr. Rekha, I think.
She's 1 year
Rekha.
junior to me, Swarnareka. Yeah.
Sir Rekha. So,
We were there yesterday in St. John's for that consultative meeting, Kangaroo Mother Care.
so we will decide if this time suits both the platforms, the India and Bahrain, after today's event and attendance,
Very good.
because I'm not sure how our side of the story goes. Let's see.
Let's see, it's just a beginning. We shouldn't be worried about that.
Yeah,
The people who have come should say that it's good and please don't miss next time. That's a good campaign, if they say.
That, needless to say, will happen. But, it.
Hi, Dr. Vasant.
I'm traveling from Rajahmundry to CT2 airport.
It's very, very nice of you to join. Dr. Vanitha, Dr. Vanitha.
Hello, Doctor.
Hi.
I'm
Dr.
Dr.
Vasant
Vanitha.
Kaletkar is the president-elect of IAP. He'll be
Hello,
taking
Dr.
over in
Vasant.
2025, and
I'm inviting you for Pedicon, that is in month of January 2025 at Hyderabad.
Dr. Ranjan was telling about this, Doctor. My whereabouts
Ranjan,
during that
convey the
time
message.
may not suit the event, but
Where are you?
I would love to come. I will try and make it, Doctor. Thanks for the invite.
Please try. You will be our guest.
she is the president of the Bahrain branch of IAP.
Excellent.
Consultant pediatrician.
In Bahrain, yeah.
Okay,
but then there was not much of activity that was happening as in IAP Bahrain. This is our bid to revive it. So
but you should come.
I will try and make it, Doctor.
Yeah.
Vasant is a great host.
Yeah.
Whenever conferences are held in Nagpur, I enjoy.
No.
Great.
Hyderabad also, Ranjan, you will enjoy. No? Hyderabad also. You will enjoy.
Yeah.
Hyderabad will be superb. And academics as well as all definitely. Hospitality, academic, and venue is good. So I request you once again.
Sure, Doctor. Really, many thanks for the invite.
Yeah. No, I talk about Ranjan. We should have some physical activities also. This virtual activities will be there, but there should be some physical activities.
You'll be planning one in the next month, Doctor. Probably, if depending on the success of the event, we will plan more of it, Doctor.
Yeah. 100%. We'll do. So I'm here.
Dr. Vasant, you will be on for at least 15 minutes, no?
Yeah. Only at the time of check-in.
Because inauguration, Dr. Vanitha may ask you to say a few words. As president-elect.
Yeah. Okay. You, Dr. Vanitha, you know Dr. Rashid?
Doctor?
Rashid, R-A-S-H-I-D. He's from India. Bahrain. He's in Bahrain pediatrician.
Not familiar. Okay. He is in BDF, is it?
But I don't know where he's working, but it's in Bahrain. He's in Bahrain. He's nearby my own place. So, and from Maharashtra, India.
Okay. I think we are talking about the same person. I think I know who you're talking about. He used to be in BDF, now in a private organization.
Yeah. Right. No, it's so nice. Yeah. Rajan, if I get disconnected, I will join within 5 minutes because I have to do check-in also, no? That because my flight is by 3:30.
Okay, Vasant, the very fact you have come and said hello is very, very courteous, and thanks for that.
No,
If
it's
if
fine.
we see you on the screen, we will call you. Huh?
Sure,
Yes,
sure,
doctor.
sure.
Thank you, doctor. We'll meet.
Thank you. Yeah,
Bye.
I will be there till the time of check-in. I will be there. House clean.
Thank you. Thank you.
Hand luggage. One bag, if they can accommodate, it's okay. Otherwise, no.
ಗೊತ್ತಾಯ್ತಲ್ಲ ನಾನು ಹೇಳಿದ್ದು ಡಾಕ್ಟರ್ ವನಿತಾ ಇದ್ರೆ
ಗೊತ್ತಾಯ್ತು
ಒಂದು
sir. ಇದ್ರೆ last
ಟೈಮ್
message
ಇಲ್ಲದಿದ್ರೆ ನಾನು ಮಾತಾಡುದಿಲ್ಲ, ಅವ್ರು ಮಾತಾಡ್ಲಿ.
I'll open the floor to all of you, doctor, and then you can.
ಅಲ್ಲ, ದಿಸ್ ಇಸ್ ದ ಓನ್ಲಿ ಒಕೇಶನ್ ವಿ ಗೆಟ್. ಅಲ್ಲಿ ಬರೋದು ಇಸ್ ಎ ಒಂಥರ ಪ್ರೈವೇಟ್ CME ಹಾಗೆ ಅಲ್ವಾ?
ಹೌದು. We'll record this alba.
Ranjan sir, president is joined.
ಹಾ.
We reach, no?
Saji, I'm not seeing him.
He's there. He's muted. I think can just say hi.
Who?
Basaraj sir.
Basaraj sir, yeah. Hey, call him, Basaraj ko. Call him.
No, he's joined. Basaraj sir
He's
is
joined. I think he has to unmute and make himself visible. So he might do that soon.
Unless until the flight will land, they should not start boarding. They will not. Huh?
Last minute voting going on, Vasant. You have to unmute yourself.
Actually, both the IAP, CIAP also came, na? CIAP voting will be going to start by 4th of this next month.
Yeah, I saw the program.
Yeah.
This thing. What is that itinerary?
Itinerary. That's why, na? But it's something like the victory we know who is going to win.
Because last minute voting, lot of problems coming up because.
Yeah. See, this e-voting, this problem are expected.
Correct.
Yeah.
I'm one of the election commissioners.
Sorry,
Hi, Kavita.
Talk
Hi,
with,
hi.
How are you?
Good. You can hear me, right?
Of course.
Properly.
Visible, and I can hear your melodious voice also.
Oh my God. So, maybe I'll use my mobile to speak because there's something wrong with my computer audio, looks like.
Illa, it is, you're very nicely audible.
Okay. Sure. Can I share my screen and see if it's okay?
Saji?
Can I share my screen and just check if it's okay?
Yes. You can.
Yeah, that's a good idea. Do it. Namaskara.
Namaste.
Yeah, madam, we can see the screen, ma'am.
Okay, thank you. Thanks.
I've given the access.
Yeah, you can try run it. You have another 10 minutes. So,
hi, Basavaraja. Basavaraja.
Vasant, where are you?
Just Rajmundry, leaving Rajmundry, there's a
Okay,
3:30
okay.
flight 3:30. I'm just entering airport.
Yeah.
Yeah, it was good, huh? Good.
Sajay, can you call Yogesh and Atanu? You have another 10 minutes of time.
ಹೌದು.
Program is
ಬಸವರಾಜ,
what? Vasant?
Yeah.
Rajmundry? Okay.
Rajmundry was very good, huh? Yes, sir.
Yeah.
Good strength. 40,
Very good. Very good.
42 was there, and myself, Singarvelu and Ramakrishnan was there. It was going on well. It is a very interesting module, na? ITI.
Yeah.
Everybody was interested. Jiri. 3.5 hours.
Yeah.
Total. With inauguration, group photo.
No, that is almost a 15 years module. It is well branded.
Yeah. Yes. I told this that this is
No, only thing is we have to brand the module so that Nilamji, good afternoon. Nilamji is making some time. Good. Devendra Sarin sir, good afternoon.
Good afternoon, sir. Basavarajan sir, Vasant sir, Neelam madam.
Good afternoon, Dr. Sareen.
Good afternoon.
Ranjan sir.
Good afternoon.
Hello, Dr. Saab. How are you? Oh, somebody else is driving too with a smart rooftop car.
Oh, Dr. Mohan,
Yeah.
Neelam, how are you?
Very good, sir. How are you? We are
Not
highly
bad.
obliged with your beautiful conductance of such seminars. There was so much to learn last time from Indo-UK. So now all excited to see this new one.
Yeah.
Dr. Neelam doing very hard work. Best
Thank you.
wishes, Neelam ji. Best wishes.
Thank you.
Yeah. Sir. How come you got the time, Neelam?
I came back yesterday. I was in Jharkhand. Today I was in West Delhi. So now I'm in Delhi. I've landed and I'm moving.
So welcome to Professor Yogesh Parikh, our honorable dynamic secretary.
Yogesh sir, good afternoon.
Thank-
Yogesh sir, good afternoon.
Good afternoon.
Hi, Yogesh. I
Hello.
can't see
Good
you,
afternoon.
but good afternoon. There. Now you are visible.
Good afternoon, Ranjan sir.
Good afternoon, Yogesh.
Yeah.
Your name is not coming, sir, on the bottom, Dr. Anjan. You should type on the computer.
No, it is
I
coming.
can
it is
see
coming.
my name, Ranjan
Okay.
Pejawar here.
Okay.
ಬಸವರಾಜ್.
Yes, sir. Good afternoon, sir.
ಬಸವರಾಜ್, ನಾನು ಅದು ನಿನ್ನೆ ಮಾತಾಡಿದೆ.
Okay.
He's in under full control. What he says is, ನಾನು ಹೇಳಿದಾಗ ಅಲ್ಲಿಂದ ಸಿಂಗಾಪುರಿಂದ ನಿಮಗೆ ಮಲ್ಟಿಪಲ್ ವೀಸಾ ಇರೋದ್ರಿಂದ ಈಸಿಲಿ ಹೋಗಿ ಬರ್ಬೋದು.
Okay. Once ನೀವು ಮಾತಾಡಿದ್ರೆ ಅಂದ್ರೆ ಮುಗಿದೋಯ್ತು.
ನಾನು ಇನ್ ಡೆಪ್ತ್ ಮಾತಾಡಿದೆ. ನೋಡ್ ಮಾರ ಗಡಿಬಿಡಿ ಆಗ್ಬಾರ್ದು. ಸರ್, ನಾನು 3 ವಾರದ ಹಿಂದೆ ಹೋಗಿ ಬಂದದ್ದು ಸರ್, ಅದೇ ರೂಟ್ ಅಲ್ಲಿ ಹೇಳಿದೆ.
ಸರ್ ಏನಾರ ಇದ್ರೆ ಸರ್ ಮಾತಾಡ್ತಾರೆ ಅಂತ ಹೇಳಿದೆ.
Dr. Vanita.
I think she is some network.
No, she must be speaking to her CEO.
Correct. Yeah, local thing.
Just to remind them.
Good afternoon, Vanita madam. Good afternoon. Good to see you.
Good afternoon, Basurajji, and good afternoon, everybody.
Yeah, good afternoon, madam. Good
Welcome, Hima Bindu.
Yogesh ji, your technical issues is solved.
Thank you, sir.
Oh, I am in the airport. I am audible and visible.
All are in the airport
Yeah,
or
you are
driving from
visible and
airport.
audible, Yogesh. You are visible.
Hello.
Good afternoon,
Yeah,
Dr.
visible and
Baswa.
audible.
Good afternoon.
Good afternoon, Kesavelu
S.A.
sir.
Krishna sir. Good afternoon.
आप कैसे हो?
हाँ ठीक ठाक सर, ठीक ठाक सर.
Dr. Kesavalu, good afternoon.
Good afternoon, Kesavelu sir.
ನಮಸ್ಕಾರ ಕೇಶವ್ ಹೇಗಿದ್ದೀರಾ?
Hema Bindu
Dr.
madam, good
Krishna.
afternoon.
Good afternoon, Dr. Basava.
Good afternoon sir,
Good
Krishna sir,
afternoon.
good
Good
afternoon.
afternoon, Jackson.
Yogesh sir, good afternoon.
Good afternoon, sir. Good afternoon.
Good afternoon, Yogesh bhai.
Yeah, sir. Good afternoon.
I think they've joined.
Good afternoon, one and all.
Yeah, good afternoon, Dr. Vanita madam, good afternoon.
Yeah,
Good to see you all.
good to meet you all. Can I start with the introduction, please? Because I'm not seeing myself in the panel there. Am I audible?
और चाहिए
You're
कुछ?
audible. You're audible.
पक्का और चाहिए तो है.
Make it with a view to the great gallery. Yeah.
You're
Okay.
audible, Dr.
I
Vanita, but
can
you
find myself there.
sound
I'm
distant.
not in the crowd there.
They can spotlight. Yeah, they have the only spotlight because they are the ones who are isn't it?
I am Dr. Vanita, if you can figure out who I am from the group. I'm Dr. Vanita. Let me introduce myself before introducing others. I'll be the host for today.
Thank you, Vanita. Good afternoon in India.
We need to unmute her. She got muted by default. Vanita, you got unmuted.
Good morning to everybody.
Yes, good morning, good morning.
Sir, good
Good
morning,
morning.
sir.
Good
Very nice to
morning.
see you.
Good morning, Kotresh.
Yes, good morning, sir. Good morning.
Good afternoon, Kotor sir.
Oh, sir, good morning. Nice to you.
Good afternoon,
Nice to
Dr.
see you.
Pramod.
Hello, good afternoon. Good afternoon.
Pramod Jog, sir. Good afternoon.
Hello, hello.
Yeah.
Sir, Pramod Jog, sir. Good afternoon.
Shall we start?
Microphones on that.
Yeah, I think you can wait for one more minute.
Dr. Vanita, can you just say hi? I'll tell you whether you're
Check
properly
that.
audible. Unmute yourself. Unmute.
Excuse me for the little technicalities. We are logging in from our meeting room here.
Now you are quite audible. No problem.
Okay. Can I get started?
I believe one minute is left
Yeah.
for 3 o'clock. That's what Baswaraj says.
Yeah.
Ranjan, sir. Now we can start. 3 o'clock. Start.
Yeah, let's start.
Yeah, let's start.
Yes. So, President, sir, may I start?
Yes. Can I get started?
Yeah, please.
For the little knickknacks that's happening here. I am Dr. Vanita. I'm a pediatrician from American Mission Hospital, Bahrain. I'll be the host of the event. I'll be the moderator of today's CME. I welcome you all for the event, and I would want to introduce the event before actually getting started with the CME. This is our official inauguration also. So I have Dr. Basaraj, the IAP president, and the welcome doctor. And we have Dr. George Sherian, our CEO, who has been the visionary who gotten started it all. So we will have introductory conversation from both the IAP president and Dr. George Sherian before having the word from other distinguished IAP dignitaries who were instrumental in getting it all started. So line of introduction about this IAP AMH collaboration before we get started. IAP, most of the people in the panel, as they are aware, is Indian Academy of Pediatrics with a 60-odd years of legacy in the academics field of pediatrics. 50,000 odd membership exemplifies the importance of IAP in this field, and a lot of flagship CPD products and contribution towards guidelines in national healthcare guidelines exemplifies the importance of IAP in this landscape. American Mission Hospital has a legacy of equal importance in this part of the world. We are the first healthcare providers, as we can say, from this region, and we have 120 odd years of quality healthcare provision in this part of the world. Dr. George Sheridan has been our CEO, who's a visionary in this, recognizing the importance of education and providing healthcare. And that is how, on one meeting between Dr. Ranjan Pejawar, Dr. George Sheridan, and Dr. Deepak Abraham, a collaboration between IAP and AMH was planned. And we took it from there to start an initiative of IAP AMH collaboration. We have Dr. Mohammed Salman, who is a champion of CMEs in Bahrain. So his contribution to get this initiative started and plan an initiative where a didactic session of CME from experts of IAP will be complemented in the same field by Bahrain's perspective with the expert from Bahrain. This will now be a planned out seminar, which will be in the fourth Sunday of every month. And we will suitably complement each other's education expertise to develop to fill the gap of the education CPD needs in the pediatric practice community in Bahrain and surrounding parts of Gulf. So we have started with good vision. We hope to have a good education experience with the stalwarts of IAP pediatrics contributing towards it. Many thanks to all the IAP dignitaries who have contributed to the conception of this event. Now, I would request Dr. Basuraj, the IAP president, to say a few words before opening the floor to our CEO, Dr. George Sheridan, who will be talking in this event after the inauguration by the IAP president. Thank you.
Thank you, Anita, for giving an overview of today's context of a meeting, which Indian Academy of Pediatrics in the year 2018. It is a 48,000 member organization with 376 district branches and 31 state branches with 24 subspecialty branches. So as a vision which has been conceptualized in the year 2018 when Dr. Santosh Sohan was the president at that time, and our present dynamic secretary, Professor Yogesh Parikh, was also an executive board member. Dr. Ranjan Pejawar was an international convener of our committee, where we had a lot of collaboration with a lot of international organization, and also we have started in branches of an IAP behind the bud. That was the whole concept we started in the year 2018. And to share our academic knowledge and having a good interaction with the pediatrician amongst all the members across the world. That's how the whole concept is started. So today we have another benchmark in the Indian Academy of Pediatrics when we signed with an MOU with an AMH hospital, and we are thankful to George Cherian, who is the CEO of an AMH Hospital. Thank you, Dr. George, and for this, and our Chief of Medical Staff, Dr. Deepak, and we are all very grateful to you. This is how this program is being started. Our Indian Academy of Pediatrics with a 48,000 member organization, which is eagerly looking to spread our wings and knowledge so that all it will be beneficial to the win-to-win situation. That's how the things which will happen. So testimony to that, today we have been conceptualized one of the most important non-communicable disease. The United Nations and on all the international forum, now the shift is moving towards an non-communicable disease. That's where the topic which has been chosen by Dr. Ranjan Pejawar to look into the Indian perspective, and wherein perspective the obesity is one of the most important rising problem, where the Indian Academy of Pediatrics, which is to prevent the obesity, is doing a lot of community-oriented work, and also how do we address as a pediatrician, as an organization, we are working with our pediatrician. So this is an excellent topic. That's what Dr. Ranjanji has been chosen. So I'm sure that this is a beginning step, which will make many more things to come in the line with our executive board and our honorable president-elect, Dr. Vasant Kalashkar. He was there. He was just boarding the flight. That's why he may join at any point of time. And Dr. Upendra Kinjekar, our immediate past president, and our OB and EB and our dynamic secretary, Professor Yogesh Pari, who is going to be the next year also the secretary, Dr. Atanu Badra, treasurer. So together we will be looking forward to take it to the other mutually acceptable, agreeable collaboration of an academic thing, and also beyond that. So that's where we are looking at. With this, we would best wishes for the today's event. Looking forward to meet you all in physically also in the next month. I'm sure all these things will make a big difference in the pediatric community and overall child care is concerned. That's where our Indian Academy of Pediatrics really looking at it. Thank you, Dr. Vanitha, for inviting me to talk, say a few words. Before George Cherian comes, you can request our Honorable Dynamic Secretary, Professor Yogesh Parik, is about to board on flight. You can speak few words. After that, you can add it over to you.
Thank you, our beloved President, Dr. G. Basaraj sir, and our IAP Bahrain branch President, Dr. Vanitha Jagannath Madam, with the help of our International Liaison Committee member, Dr. Ranjan Pejawar sir, our chairperson of the committee. He had put lots of efforts for this inaugural webinar of the Bahrain branch with the collaboration with the mother organization IAP. And we welcome our President, Dr. Basaraj sir, President-elect Dr. G. Basaraj sir, Dr. Upendra Kinjekar, Dr. Atanu Badra, and Dr. Ranjan Pejawar sir, American Mission Hospital CEO, Dr. George Cherian sir, Dr. Deepak Abraham sir, and Dr. Vanitha madam. Today's both the speakers are aptly selected by Dr. Ranjan Pejawar sir and Dr. Vanitha madam for the most important non-communicable disease, childhood obesity, and the overview of the Bahrain pediatric societies having concern regarding the pediatric obesity. So both the speakers, Dr. Kavita Bhatt madam and Dr. Khadija Ali, will deliver best for both the topics. And we hope this will be our first webinar, inaugural webinar, and it will be the ongoing activity for the next years also. So thank you very much, sir. I am so best wishes for the great success of this program. Over to you, sir. And
thank you, Dr. Basaraj and Dr. Yogesh Pari. I welcome Dr. George Cherian, our beloved CEO, whose vision has been the force behind conceptualizing this particular event. Dr. George, may I request you to say a few words to start this meet? Thank you, Dr. George.
Colleagues, thank you very much for this opportunity for us to gather together And what is unique about this is you've got a prestigious academy like the Indian Academy of Pediatrics joining forces with a hospital in Bahrain. This is the first hospital, by the way, in the region, as Dr. Vanitha said, and we are close to 125 years old, and we have a mothership or a collaborator in CMC Vellore. In fact, both these hospitals were established by the same group of missionaries as the Arctic Mission and the Arabian Mission. So our history goes back to, I think, 1900, when both these institutions were established. And the other unique thing about this is being not just the CEO and the Chief Medical Officer of this organization, I'm also a pediatrician, and like Dr. Ranjan, I'm a neonatologist. It is pretty rare that neonatologists usually end up being chief medical officers because we just love to be in scrubs and in the NICUs. I mean, I was an adrenaline junkie for about 28 years of my life before I switched into wearing a tie and a suit and running a hospital. But I always say I still miss my babies. I know that Ranjan does both, but my job is much more administrative these days. So, and again, coming back to a perspective of why this is important for both us as pediatricians, the pediatricians from the Indian subcontinent and IAP is as follows. There are close to over 90,000 Indian physicians globally just between the US and OECD countries. This is excluding the Middle East. In Bahrain, there are 350,000 Indians in a small country where the total population is just 1.5 million. So Indians form the largest expatriate community here. And the early physicians that actually came to Bahrain in the 1920s were from the Indian subcontinent, even though the American Mission Hospitals was established by American physicians in the 1920s, way before oil was discovered. Physicians from India came here. And if you remember a name, as pediatricians, we might not know the name, but there is a name called Dr. Jacob Chandy, who was the father of neurosurgery in CMC Vellore. He established the first neurosurgical unit in India. He actually worked at the American Mission Hospital in Bahrain, and the missionary doctor sent him to Montreal and to the US to train, and he came back and opened up the first neurosurgical unit in CMC Vellore. So there is a lot of connection between this institution, institutions back in India, and we have quite a number of physicians who still work here. So it is nice for us to, I would almost say, reconnect. We are not connecting for the first time, reconnecting with the heritage of the Indian Academy of Pediatrics and the pediatric department here in Bahrain. And it is my vision, exactly like your vision, Ranjan, because Ranjan is an international player, is to bring together pediatricians from different walks of life where the context in which we practice our specialty might be very different, but the core needs of the child comes first. Because in pediatrics, we are not just treating a child, we are treating the whole family as a whole. And in my days, when training in pediatrics, we had we had no childhood obesity then. We had kwashiorkor and marasmus that we had to deal with. And this childhood obesity seems to be a new NCD that has cropped up over the last 20 years. And now I've got two cases, Dr. Kavita and Dr. Khadija from India and Bahrain, who are pediatric endocrinologists. And again, pediatric endocrinology did not exist as a specialty when I trained. So these are all new specialties that have come up. Adult endocrinologists, there were no pediatric endocrinologists. So we are now in a phase where medicine is so fast developing. We are in an era where there is so much of new knowledge being added each and every day, not just through publications, but in the way how we practice pediatrics. And it is important that continuous learning becomes a part of our everyday life. Previously, we all thought that by the time you finish your MD pediatrics, you've been there, done it, and that's it. And so, in fact, we continue to learn each and every day. And I think learning stops once we finally stop living and we have put 6 foot under the ground. And another statistics I just want to sort of point out to you is that they looked at the batch of graduates from All India Institute of Medical Sciences from 89 to 2000. And there was a shocking statistic that came across. Nearly 60% of all the graduates of India's most prestigious institute, All India Institute of Medical Sciences, these physicians are abroad, mainly in the US and in Europe. So there's a steady migration of physicians still happening from India to abroad. And you can see if you take any, I think 1 in 5 physicians in the US are from the Indian diaspora. So there's been a lot of migration of both intellect and people across boundaries now. And fortunately, learning is no longer siloed into where you live or practice. This very technology of Zoom that we are sitting around and talking means that knowledge can be, available everywhere for anyone. So there's no longer low-income countries and high-income countries and middle-income countries. No one has got a claim over knowledge. So as long as we use the knowledge for continuous learning and development of physicians globally, then the Indian Academy of Pediatrics' has greater vision to impart knowledge in pediatrics right across India and across the globe. That mission will be fulfilled. Our mission is just the same. We are a not-for-profit hospital. We exist to provide outstanding healthcare to not just our population, but using collaborations to take our knowledge and expertise to the far corners of the world. And with that, I will stop because I'm not a speaker. The speakers are patiently waiting, Dr. Kavita and Dr. Khadija. So thank you so much. And this is a beginning of a long collaboration, and I wish it every success. Thank you.
Thank you, Dr. George, for those encouraging words. From here, I would like Dr. Ranjan Pejawar. He is the champion. Circling back on what Dr. George told, be a part of this global community, representing continuous professional activities. As long as we live, we need to strive to learn, to keep our knowledge on. So Dr. Ranjan Pejawar, an introduction to him at this context would be, he is the person as an international liaison who conceptualized the whole program and singularly made his effort to accumulate all the subspecialties across the breadth of India to design the whole CME. So Dr. Ranjan Pejawar, may I ask you to introduce this collaboration as well as give a few words before we start this evening. Dr. Ranjan Pejawar.
Thank you, Dr. Vanitha. Yes, I don't want to take too much of time. We are going to hear from the two pediatric endocrinologists. However, I must say, first, congratulations to the President Basavaraj of IAP and his team who readily agreed for this program. And I had no problems. When I first spoke to Dr. George Cherian and you, I knew this is going to be a successful program. Without any hesitations, you people agreed for this collaboration, and that is great. As they say, well begun is half done. So I am sure this program is going to sustain itself and grow from strength to strength. IAP has always had the vision of spreading its wings outside India. As Dr. Basavaraj said, this happened few years ago, pre-COVID, and now it is getting more and more stronger. IAP has a branch in UAE, now a branch in Bahrain. It's got a Friends of IAP group in UK. Oman probably is going to have a IAP branch. IAP has had this year a MOU with Bangladesh. They already had an MOU with Nepal. So things are really moving well. And as Dr. George Cherian said, it's now a global village with all the technologies and all the expertise around. Everybody is learning from everybody, and everybody is sharing what they know with each other. And that is the whole idea. And today's people are concentrating on NCDs, non-communicable diseases, and obesity comes under that. And we know obesity has a history starting from the prenatal period to adulthood. So there is an angle about NCD at all age groups, whether we like it or not. And we need to know this, and we need to know it from the pediatric endocrinologist especially, and make sure that this epidemic of obesity, an epidemic of NCDs do not upset our health system and our healthcare activities. So today it's an important topic, and I do not want to stand between the speakers and the delegates who are attending to learn about it. So I thank everybody who are involved in this activity, and I hand the mic over to you, Dr. Vanitha.
Thank you, Dr. Ranjan. Now, let's move to the actual event. Today's event is a CME on pediatric obesity. I will be the moderator of the event. May I invite Dr. Kavitha to come over to the floor to get started with the event. Let me introduce Dr. Kavitha Bhatt. Dr. Kavitha Bhatt is a pediatric endocrinologist from Bangalore. Currently, she is she's practicing from Bangalore and Astor Hospital. She hails from a background of fellowship in endocrinology from Leeds and USA. And she would start the CME today on an important topic, as the distinguished speakers already talked about, pediatric obesity. Obesity is a very complex disorder. Until of late, the concept of it was just about nutrition, but the guidelines now focus on the complexity and opens our pediatric community to deliver in certain deficiencies, which has made it an epidemic, which will be educated to us about from Dr. Kavitha and Dr. Khadija, so that we know from this educational experience as pediatric community, how would we serve to prevent this complex disorder, and how do we serve treating this complex disorder. May I invite Dr. Kavitha to get started with the CME.
Thank you, Dr. Vanitha, for the kind introduction. At the outset, I would like to thank Dr. Ranjan and the Indian Academy of Pediatrics Bahrain branch for having given me this opportunity. I think pediatric and adolescent obesity is the most common chronic disease that we see these days in our practice, either as ped endo or as pediatricians. So I thought I would share some latest tips and guidelines that is around. And this is a very nice guidelines that has been put together by the American Academy of Pediatrics. And a lot of my talk would be drawn from this with certain practice-specific modifications, because each country and each state has different challenges with implementing guidelines. So I would also share the way we modify these guidelines for our use. So this is the Indian statistics. Obesity is the prevalence of obesity is 8 to 12% in Indian children, and the prevalence is increasing, with urban obesity being much higher. Lifestyle changes and have played a significant role in this increasing trends. And it's seen that the prevalence also increases with age, with adolescents having higher prevalence compared to younger children, mainly on account of reduced physical activity and increased screen time. In urban areas, boys tend to have a higher prevalence of obesity compared to girls, but this gap is narrowing. This is what it is in India. Now, coming to, I think I will straight away, because there is so much to discuss about obesity, I will go straight on to the points as clinicians for us, how we can assess and go about managing our patients with obesity. So all of us need to use BMI as a screening tool. I'm sure most of us are. BMI is weight in kilograms upon meter square. And there are BMI charts specific for age and gender that tracks BMI across ages. So just to give a hint of how BMI is so important, there is a child whose BMI is normal, but if the child's BMI has jumped from the 25th to 50th percentile, though it's within the range of normal, this is a child at risk for obesity in a few years. So tracking BMI is very important. And also, BMI needs to be tracked in certain other chronic illnesses like steroid treatment, which I'll come to later. So BMI is both useful as a screening as well as a diagnostic tool. So though the gold standard is DEXA, it's very expensive and difficult to implement in our day-to-day practice. So BMI chart is a very simple, inexpensive, and useful tool. And many studies have validated this as a valuable tool for monitoring weight gain. So we all know the definitions of BMI. A BMI above the 85th percentile is considered as overweight, and above the 95th percentile is defined as obesity. And severe obesity is the BMI equal to or more than 120% above the 95th percentile, which approximates the 99th percentile. There are now extended BMI charts available. Both the IAP as well as the CDC charts make provisions for this extended BMIs. So this is the CDC growth charts, which helps us to evaluate class 1, class 2 obesity, the excess, which fall in the category of extremely overweight. So when we're evaluating any child with obesity, we have a checklist of the risk factors. In addition to asking the family, when did it become a concern for the family, and what were the factors around that time that could have, as per them, could have triggered off the weight gain. We also have a checklist of the risk factors that we look for in any child who presents. Now, this is a little bit crowded table. This is taken from the consensus guidelines. So we know that it's multifactorial. I'm not going into the policy factors or neighborhood and community factors because this is beyond the scope of most of us to handle. But definitely the family and home environment is a major determinant. Parenting, feeding styles, parents use food as a reward or punishment, and the snacking behavior. There is a free access to a lot of sugar-sweetened beverages, snacks. They have access to mobile phones, especially after COVID, because most of the class schools went online, and that habit has remained with children to use the mobiles. This is what I'm finding in our practice, that they have gotten hooked on to the mobile phones and spend hours. Parents are unable to address this because both the parents are working, especially in urban areas. We also need to look for genetic factors. Monogenic causes should be suspected when the obesity is very early onset, are less than 6 months of age. So sometimes when we ask the history and the parents say the child has always been obese, we tend to track the weight right from infancy onwards. And if there has been a significant weight gain in the first 6 months, and there is a family history of consanguinity, there is a family history of obesity, which may or may not be early onset, and there is a child who is demanding food constantly, we do think of genetic factors, monogenic syndrome like leptin, melanocortin receptor, so pro-opiomelanocortin receptor gene mutations. I'll come to that later. So these are all the factors that could affect, that we need to look for when we see a child with obesity. The risk for obesity starts in pregnancy. Maternal history of diabetes is important because studies have shown that gestational diabetes increases the risk of obesity in the first 10 years of life. So, and the counseling needs to start there itself. You know, when a mother with gestational diabetes delivers a child, we need to stress the importance of monitoring the BMI. We need to stress the importance of having a healthy lifestyle. So it starts at birth. Our preventive and monitoring strategies start at birth of this child. Extreme maternal weight gain during pregnancy has also been associated with obesity. Birth weight, large for gestational age babies, there is a greater incidence of obesity in such babies. Even small for gestational age babies, if they gain weight in the first 2 years of life, which is determined as a rapid catch-up in terms of weight, these are red flags, because children born small for gestational age, their BMI, the BMI at which the risk factors with associated obesity develop may be much lower than what is recommended. So we can't wait till that child reaches the definition of obesity or overweight before we start reacting. So what is recommended is this: small for gestational age children or babies, we need to advise parents on the optimal rate of weight gain in the first 2 years of life. Studies have shown that it should not exceed the 25th percentile. The catch-up weight gain in the first 2 years in a small for gestational age baby should not exceed 25th percentile, or should be at least less than the 50th percentile max. Otherwise, the risk of future obesity and metabolic syndrome developing at much lesser weights is much higher in this category of children. So again, these are all the checklists, like children with, we need to screen them for endocrine. These are all the high risk children. The secondary factors, like suppose there is a child who's undergone cranial irradiation, there's a child with Down syndrome, Prader-Willi syndrome, autism, or a child with psychiatric illness who is on antipsychotics. So these are the children who are at risk for excess weight gain. So in our physical examination, in our history, we need to bring out all this. I'm sorry, I'm diverting a little bit. I'm bringing in all the clinical things into this so that there are some things which we may miss out if we just look at the guidelines. That's the reason. So these are all the genetic syndromes associated with weight gain, which have specific physical findings. I won't go too much into this because this is available. It's open access and anyone can go through this. They can prepare their own checklist to check if these features are there in our patients. Now, coming to the medical history, it follows the usual format. We ask, when did the weight become a cause for concern? If the weight is a cause for concern, if at all, for the family, and if so, when? And what do they think could be the trigger? Often the parents give some insights. You know, in India especially, they take alternative systems of medicines for things like asthma and wheezing. And unless we ask them, did you take those, they may not come up with that. And then you realize that once they're taking those medicines, the appetite has increased, and that could be that could have been the trigger for weight gain. So we need to go into the history of present illness about the obesity, the onset and the progression in detail. We need to, I'll come to a table of review of systems, which is very important in evaluating the cause of obesity. Even though it's exogenous, we need to evaluate the cause so that we can tailor make the treatment. Family history of obesity is important because it not only sets the environment for the child, but also it could uncover some genetic causes and some behavioral issues which could be there in the family environment. The parents' behavior, the parents' approach towards snacking. So we need to take a detailed history regarding all that. A medication history is, of course, important. Anti-epileptics like valparin, phenytoin, and carbamazepine can cause weight gain, including some antipsychotic medications. So it's important to take a detailed history. Steroids, inhaled or topical in very high doses. You know, there was a mother who was using a topical steroid for diaper rash, and we had a 9-month-old with iatrogenic Cushing's. So we need to take a detailed medication history. Often it may not be obvious. So social history, again, the family and the social history go kind of they're overlapping. We need to look into this. We need to take a detailed dietetic history as well as physical activity history. We need to involve our psychology and psychiatric colleagues if we suspect any behavioral health or disordered eating in the child. So there are various tools available to uncover these behavioral or eating disorders in a child with obesity. So this is the review of system, which I consider the most important in approach to a child, in taking the history of a child with obesity. So these also deal with the comorbidity. So we need to ask for any history of how the child eats, whether it's a behavior, whether it's a binge eating behavior or whether it's a hyperphagia. Hyperphagia usually has its onset when they're very young and it's insatiable, like how we see in Prader-Willi syndrome. Whereas binge eating disorders is more seen in older children, approaching adolescence, and it could be related to other psychological morbidities, comorbidities like depression. So if we suspect that, we need to take the help of our psychiatry or psychology colleagues. Respiratory symptoms are very, very common in obese children. A simple question like, does a child snore and sleep? Have you observed the breathing? Are there pauses in the breathing? Is a child excessively sleepy during the day? Is there daytime somnolence? So these all point to sleep disordered breathing or obstructive sleep apnea, and we need to get sleep studies done. This is fairly common in obese children. Gastritis kind of symptoms are common in obesity. If an obese child has excess thirst, urination, we need to keep in mind that this could reflect the occurrence of diabetes in this child. So we need to screen. I'll come to the screening test that we need to do in any overweight child. In a teenage girl, menstrual dysfunction needs to be looked into. There are recent consensus guidelines for the definition of irregular menstruation in an adolescent. If the child is 1 year post-menarche, any irregularity is acceptable. If the child is 2 year post-menarche, a cycle length of less than 21 days or more than 45 days is considered as irregular. If the child is more than 2 but less than 3 years, more than 2 years post-menarche, a cycle length of less than 21 days or more than 35 days is considered as irregular periods, or a total number of cycles in a year of less than 8 is considered as oligomenorrhea. We all know that oligomenorrhea is one of the 2 criteria for diagnosis of polycystic ovarian syndrome. In adolescents, we need only 2 criteria for diagnosing polycystic ovarian syndrome, which is very common. One is oligomenorrhea, as by the adolescent definitions, and second is clinical and or biochemical evidence of hyperandrogenism. So clinical evidence, we use a modified Ferriman-Galloway score. We have pictures, we tick it. So we score, or we do the total and free testosterone. So testosterone needs to be done by the LCMS method, which is not very easily available in India. One of our labs does it. Otherwise, we may get falsely elevated or low values if not done, because in other methods, the other steroids interfere with the assay. So it's important we do the total testosterone by LCMS method. A total testosterone of more than 55 nanogram per ml is indicative of biochemical hyperandrogenism. So we need to screen our teenage girls for these, or we need to warn our peripubertal children that entering puberty with excess body weight is a trigger for PCOS, and the importance of implementing lifestyle changes before it actually happens. Ultrasound criteria is not a criteria for diagnosis of adolescent PCOS. Orthopedic complications are not unknown. Hip, knee joint pain, pain in the feet are all very common. Very rarely, slipped capital femoral epiphysis can happen. Blount's disease, which is bowing of the legs, which causes bowing of the legs, can happen due to increased weight bearing. There are specific radiological signs that distinguish Blount's disease from the physiological bowing that one sees in very young children. So these are things that needs to be considered. Mental health is definitely a concern. Well, this is not my domain. If I suspect, I refer them to the specialist. Sorry. So dermatological manifestation like skin tags, acanthosis nigricans, striae, we all see. Children with obesity could have enuresis, nocturnal enuresis, and other behavioral issue. This is mostly a behavioral issue, or it could be an obese child who has started bedwetting. It could be a reflection of diabetes mellitus having the child having developed diabetes mellitus. So neurologic persistent headache could be a sign of idiopathic intracranial hypertension, a complication of obesity, and the other symptoms of daytime somnolence could reflect an obstructive sleep apnea or sleep disordered breathing, as the terminology is now referred to. So physical examination, we need to measure the blood pressure, and we need to check the blood pressure against the charts. There are blood pressure charts based on the height percentile for gender and age. There are the height percentile. So all these three factors should be taken into account when we comment on the blood pressure of the child. And we need to document at least 3 readings. There are different other causes which we need to rule out. If we have an obese child with hypertension, we need to make sure we are not missing out other causes of hypertension, as mentioned here. So increased heart rate, changes in height velocity, obesity, exogenous obesity is associated with a height acceleration initially, but finally they may not end up to be as tall as their peers, because obesity also advances bone age. Obesity could trigger slightly earlier pubertal onset because adipose tissue produces leptin, which has a permissive role in pubertal onset. And so we need to document changes in height velocity along with the changes in BMI. So these are all the physical findings, which is given in the consensus guidelines, which is of the American Academy of Pediatrics, which is open access. We need to look for tonsillar hypertrophy in a child who's snoring and has tonsillar hypertrophy. It's quite possible that the adenoids are also hypertrophied, and adenoidectomy may help the child. So we need to pick up all these signs in the physical examination. Gynecomastia is common in boys, prepubertal gynecomastia, because adipose tissue has aromatase enzymes, which converts the testosterone in the bloodstream of even prepubertal boys to estrogens. We all know of the non-alcoholic fatty liver disease. Excuse me, it has got a new terminology now, metabolic syndrome associated liver diseases or something like that. So we do see children with elevated liver enzymes, and obesity, which is earlier used to be termed as non-alcoholic fatty liver disease, is one of the leading causes of cirrhosis these days. So we, as pediatricians, we play a very important role in evaluating for the presence of this and counseling the family appropriately. All of us have seen obese children coming to us with the concerns of reduced penile length. And when we ask back, they say, yeah, the child started gaining weight a few years ago, ever since the penis seems to be small. But at birth, the penile size was normal. So most of the disorders of DSDs, which can lead to micropenis, they start at birth. So this should be a clue that it could be related to weight gain. So we need to measure the stretched penile length after depressing the suprapubic fat. And there are percentile charts for penile length measurements that we can compare the measurement with, and reassure the parents often. But again, recent studies have shown, I mean, this is a new terminology, male obesity hypogonadism, MOSH. Recent studies have shown that in boys who are overweight or obese, the penile growth may be compromised, spermatogenesis may be compromised. There has been, this has been a study which has been endorsed by the Endocrine Sciences USA. So we know that all the orthopedic complications can cause changes in gait and hip or knee joint pain. I won't go into that. So coming to the short and long-term health complications of pediatric obesity, it's mainly cardiovascular. Long-term is definitely cardiovascular. And also there are studies that say that it could increase risk of cancer, renal complications, and everything else. Pretty much it has implication on the whole body. As pediatricians, we need to screen for this. This is essential. We need to screen for the presence of prediabetes or diabetes by these guidelines. We need to do the fasting lipid profile. And of course, we do measure the blood pressure, and these are the guidelines on how to categorize the blood pressure. We need to do an ALT level. More than 25 in boys and more than 22 is kind of cause for concern. PCOS I just mentioned, obstructive sleep apnea, and psychiatric issues. These are the comorbidities of pediatric obesity. So now evidence-based management strategy for pediatric obesity would include lifestyle modifications, which is the foundation of obesity management. Everything else builds on this. If this is not there, then it's unlikely that the other strategies will have any lasting effect. And for lifestyle modification, the whole family is our patient, not just the child. So, and that is very, very challenging. And that's why we need a multi-disciplinary team to address this. There is something called motivational interviewing that has now become very popular. So I mean, I'm not very familiar with that aspect. I'm trying to learn it. There are some courses on that, but motivational interviewing is the way to go about eliciting history or commitments for chronic diseases like these and diabetes, type 1 diabetes also. So there are behavioral interventions which support lifestyle changes. Pharmacotherapy and surgeries should actually be reserved for a minority of these children. So the lifestyle management, I'm sure most of us know all this, so I won't go too much into detail. A minimum of 60 minutes per day of moderate to vigorous activity is recommended, which means what I tell my patients is that the activity should make your heart rate go up a little. Your breathing should be faster, and you should break out into a light sweat. So that is the level of physical activity that they need to do in order to mobilize the fat. So this is the motivational interviewing techniques. You know, this is mainly patient-centered. You know, the patients are allowed to decide what they want to do, and we just facilitate it. That's a basis. You know, earlier we would tell the patient what the patient is supposed to do, but those things, it's very difficult for them to sustain. Whereas motivational interviewing involves the patient himself or herself setting a goal, and the rest of the people acting as facilitators. We can facilitate goal setting for our patients and their families, and the goals should be specific, measurable, you know, the SMART goals. Well, this is from the American Academy of Pediatrics guidelines, but community-based setting and many of these things, it may not be applicable to our situation. So we need to modify this a little. So whatever, I'm not sure in Bahrain whether it's possible, but in India, our population is so huge, and we have to see so many patients in a day. So we are basically confined to we don't have the time to go out into the community and make changes there. So, but if at all there are any community-based activities, maybe we should be linking up with them to bring about some community-based interventions. So coming to the pharmacological and surgical treatment options. So ideally, pharmacological therapy should be reserved for children whose BMI is more than those who are severely obese. And when despite the optimal lifestyle and behavioral interventions, there is no improvement. Again, the foundation should not be forgotten. Most of these medicines, including Orlistat, are very expensive, so we need to take that into consideration. So which are the approved medications? Orlistat is an intestinal lipase inhibitor, which has been approved for use in teenagers more than 12 years. It reduces dietary fat absorption. It has been shown to cause a modest weight loss, but the side effect of this is that the oil just flows out of the anus. There are children who say that there is fecal soiling and it's mostly oily. So, and this limits their use, especially in school when they have these episodes. It can become very embarrassing and difficult for them to handle. GLP receptor agonists, these were first used in treatment of diabetes, type 2 diabetes, but they have been found to have remarkable weight loss properties. Semaglutide has recently been approved by the US FDA for use in children older than 12 years for obesity, when it's combined with lifestyle intervention. The side effects are gastrointestinal, but they're generally well tolerated. So this is the seminal study published in New England Journal of Medicine of once weekly semaglutide at a dose of 2.4 milligrams has brought about significant reduction in BMI compared to the group with just lifestyle intervention. This medication is not available in India. So I have used liraglutide, especially in my patients with Prader-Willi syndrome who also have diabetes, and it helped them. And there are studies of using liraglutide in children with Prader-Willi syndrome also. So, and in a few children with few teenagers with exogenous obesity also. But the response in Prader-Willi on my one patient was really very satisfying. But again, this is very expensive. Liraglutide is a daily injection, and hence there are not too many takers for this treatment. These are all highly specialized, which is not available in most countries. Melanocortin 4 agonists such as setmelanotide used in specific gene mutation. Phentermine, which is a central norepinephrine uptake inhibitors and acts in the central mechanism, the appetite regulation in the central appetite regulatory pathways. It is used as only a short course therapy. And the adverse effects include elevated blood pressure, dizziness, headaches, tremors, etc. Topiramate is a carbonic anhydrase inhibitor. Its mechanism of action in obesity is not known. It can cause cognitive slowing and is currently approved only for use in children above the age of 2 years for epilepsy and for treatment of headache prevention in children 12 years or older. Phentermine and topiramate has been approved as a weight loss medication in adults. So surgical treatment options, we don't use this very often in India. There are not many people who want to go in for this. There are certain indications for surgical treatment of obesity. And there are two types, Roux-en-Y and sleeve gastrectomy. They need to be when they undergo all these because it reduces the intestinal surface absorption, because it bypasses the small intestine. So there is reduced absorption of certain vitamins and minerals. So then we need to monitor them for development of any of these. We need to supplement this supplement vitamins and minerals because that in turn can affect the growth. Bariatric surgery has shown to be very effective and sustained. The effect has been sustained. But then again, we don't have very long-term data in pediatrics, not until they are 20, 30 years data is not available in pediatrics. So we need more data to see the very long-term implications of pediatric bariatric surgeries. So these are all the risks of bariatric surgery. I think with this, I'll stop. And if there are any questions.
Thank you, Dr. Kavita. It gave us an idea as to how complex pediatric obesity. It is indeed complex. We got an idea as to how we have to integrate different systems, and pediatric endocrinologist is in forefront to manage the case. If I can summarize, it was a good overview that you provided, and we understand that your entire CM was based on the IAP recommendation. If I can take the liberty of summarizing this, we as pediatricians would be involved in one bucket of handling the pediatric obesity. The other one bucket where I mean prevention and initial management, which includes screening and prevention. Whereas the other buckets of management would be pharmacotherapy and surgical management, where we probably would count on pediatric endocrinologists. So in the initial screening, IAP takes the burden off the pediatricians by really guiding us as to how to go about it. We have recognized the importance of not doing watchful waiting anymore. That is the main introductory element of the new revised recommendation. We are not gonna do watchful waiting. We are gonna be proactive in managing, and the listed recommendations are in the system of gastrointestinal, wet liver. Dr. Kavita highlighted the importance, where this is one of the important screening. ALT specifically has been asked of us to be one of the screening elements of pediatric obesity. Second, as pediatric endocrinologists purview, screening for type 2 diabetes is very important as pediatric obesity. Third, hypertension. These are a couple of unrecognized pediatric office practice elements, which we have to be a little more proactive and not missing out. Pediatric hypertension is an integral part of pediatric obesity, which reflects in the health of heart, which is again the cardiologist coordination would require. Another unrecognized systemic involvement is the orthopedic ailments. Osteoarthritis is very prevalent in pediatric obesity, as well as KIFI, which is a real common complication of pediatric obesity. To summarize, we would be involved. It would be useful to go about IAP 2023 recommendation, which has been timely and which has been after several years of previous recommendation, really takes off the burden of the pediatric office practice by guiding us individually at every element, not just screening, management of individual aspects Dr. Kavita highlighted. I would open the floor to Dr. Khadija. Before opening the questions, I would have Dr. Khadija's CME to give us insights into Bahrain's perspective of this particular ailment, where Bahrain is not far behind in this epidemic. This concept of TLC in our healthcare, tender loving care, is modified to be total lifestyle change, which is exemplified by every step of what a pediatrician is committed to. I will have Dr. Khadija, who's a pediatric endocrinologist from Bahrain. She is an endocrinologist practicing in American Mission Hospital currently. She hails from Salmania Medical College, which is the Salmania Medical Complex with education background from Saudi Arabia. So she will be giving us the insights of obesity in Bahrain before we have an integrated floor for questions and the panel discussion. I have Dr. Brahmara Madhuri, who is our pediatric service line head, will be part of the panel to discuss the questions after the presentation from Dr. Khadija Ali Aliola. Dr. Khadija, please take over and start the presentation.
Thank you, Dr. Vanita, for your introduction. Is my voice clear? Can you hear me well?
Yes.
Yes, okay. It's my pleasure to participate in the first academy between India and Bahrain. I'm so happy to present, and I'll give you an idea about obesity in Bahrain. I have nothing to disclose. I'll go through some statistics in Bahrain and our Bahrain government initiatives and obesity in our hospital, American Mission Hospital. Bahrain is a small country in the Arabian Gulf, and where we are compared to our neighbors, we are the third in the prevalence of overweight and childhood obesity after Kuwait, which is #1, and then Qatar. Bahrain is #3. And the overweight and obesity prevalence among men and women, this is an adult, Bahrain men, Bahrain women, non-Bahraini men, and non-Bahraini women. Green is the overweight, and this one is like semi-gray is the obesity, and we can see in men around 35% in overweight and maybe 29% in obesity. Women are more, women overweight like 38%, and for obesity almost 45%. And we can see during the years, some written in Arabic, from 2007 to 2018, overweight increased from 32.9% to 34%, and obesity from 36% to 46%. And the increment actually in all age groups, children, adolescent, and adults between years, we can see male and female, it's all in all ages, it's increased with time, which is, I think it's the same all over the world. I want to throw a booklet called Obesity in Bahrain. It's being done by our Ministry of Health and other organizations. And it's said in Bahrain, according to the WHO statistics, the prevalence of obesity in very young children age 1 to 5 years is 1.3%. However, in this age group, the percentage of children with overweight doubled over 5 years, from 2.3% in 2013 to 4.9% in 2018. And for boys and girls from 5 to 19 years, overweight affects 1 in every 3 boys, around 36%. And this is more than twice as in 1975, and about the same for girls. And for girls, they are 3 times more likely to have obesity than boys. The percentage rising from 6% in 1975 to 16% in 2016, and the rate of obesity in boys has remained at 5% for the entire period. As children grow up and become adolescent, they appear to gain weight. Figures from the school screening program published in 2019 alarmingly indicate that overweight and obesity may be as high as 40.4% in boys and 45.5% in girls between the ages 10 and 12. Half of the adolescent girls aged 12 to 15 who visited the primary care health centers were in the above normal weight range. And this is almost the same percentage that I mentioned in boys and girls. What does Bahrain did to combat obesity? We have a national committee controlling non-communicable diseases, which is a multidisciplinary national committee. It has all relevant ministries, public and private hospitals, along with relevant societies. They have regular meetings for creating policies and strategic for control of non-communicable diseases. And they have active programs engaging the public in health awareness campaign. And they put, this is in Arabic, that overweight and obesity among their things other with the smoking and diabetes, cancer, and other things. We have healthy malls. We have more than 30 malls in Bahrain. We call it healthy mall, where people can do exercise and walking from 7 to 10 a.m. Other thing, the government put 50% tax increase on carbonated high-calorie drinks and 100% on energy drinks. There is a Bahrain National Health Survey, which was done between 2017 to April 2019. Ministry of Health and the Information and E-Government Authority jointly conducted the National Health Survey. It's aimed to track health, risk factors, and lifestyle practices of Bahrain residents, provides reliable health data for the government, health providers, and stakeholders to improve the health outcome. What else? We have a mobile unit to tackle obesity and diabetes among children. It's established in 2012. It's a joint project between Bahrain Diabetes Society and Royal College of Surgeons of Ireland, the Medical University of Bahrain. It is to empower children to adopt health, concise mindset, and lead a healthy, balanced lifestyle to minimize the risk of developing obesity and type 2 diabetes. They do a lot of programs. They go to schools to do games with children to aware them about obesity. We are planning to bring them to American Mission Hospital maybe in January or February, and we will invite our children who have overweight and obesity for this event. There is a walking challenge launched by Bahrain Diabetes Society. It's to raise awareness about the benefits of exercise as part of a healthy lifestyle. Participants commit for a period of 3 months to a 30 minutes walk 5 days a week. And they do weekly groups for walking together. This is some of their events. And for patients living with diabetes, there was 100% reported improvement in glucose control and 57% reported weight loss, 83% reported reduction in stress level. And for all participants, 96% reported feeling more motivated to exercise, 91% reported motivating a friend or a family member to exercise, and 100% reported commitment to continue the walking program. So now, how is our American Mission Hospital? I'll tell you about the obesity in American Mission. I did just rough statistics from January this year till October. Around, let's say, 140 patients visited our clinic for overweight and obesity. And in those patients, we have the different complications: pre-diabetes, type 2 diabetes, dyslipidemia, elevated liver enzymes, fatty liver disease, obstructive sleep apnea, depression, and hypertension. These are some of the complications. All of our patients we kept on lifestyle modification. I give metformin for those who has pre-diabetes or type 2 diabetes, polycystic ovary syndrome. I have some, maybe 5 patients on liraglutide 3 mg 600, and only 1 patient, she will undergo bariatric surgery. In American Mission, we have a bariatric surgeon who assists this patient. Her BMI is 47. She had morbid obesity. She had severe obstructive sleep apnea. She had pre-diabetes. She was followed with me before I joined American Mission. We started the other medication, but there was no improvement. Our team, we have general pediatricians, endocrinologists, we have dietitians, psychologists, we have bariatric surgeons, and also not only in pediatric, we have a family physician here who see a lot of obesity patients. When I asked him, he see around like 100 cases per month. And I have to present cases? No need to present cases. It's just cases, maybe no need to present cases. Just that 2 brother and a sister when he did, yeah, wasn't that time for me. What I usually did for the patient, encouragement is very important. I noticed the follow up with them, especially those who see me, they come enthusiastic to reduce their weight. They send me a message regularly in weekly basis, telling me their weights. And I feel this one can help a lot. It's part of the motivation.
We are not, unfortunately.
May I ask the group to mute yourself? Mr. Saji, can you mute everybody?
Okay. So our life, your life is a matter of choices. You can choose which direction you want to go, and your child will follow your example, not your advice. And this is the booklet for where I took the statistic from the Bahraini one. There's an English and Arabic one. And thank you so much.
Thank you, Dr. Khadija, for the presentation. I think there is some disturbance in the background there. The coordinator, Mr. Saji, can look into it. Thank you. Thank you, Dr. Khadija, for the presentation. This really opened the eyes for the epidemiology of obesity in Bahrain. We are quite representative as the global community, and as Dr. Kavita presented, we belong there as the Indian statistics that was enumerated by Dr. Kavita as well. I noticed Dr. Kavita has posted a publication, which is the IAP recommendation of pediatric obesity, which is also dated 2023. IAP happened to revise the guidelines in this year to let the pediatricians monitor several specific things, and today's seminar opened our eyes to focus on that. So as I can summarize, we have to, from Dr. Khadija's presentation, what we noticed is it's the initiative from the national level that's going to bring about the change in this epidemic. Total lifestyle change happens to be the single marker which will make a difference in this complex disorder. However, both the endocrinologists presented the pharmacotherapy and the surgical management, which shares a very very small segment of how intervention in pediatric obesity is. Now we have opened the floor for questions. I think Mr. Saji can coordinate live questions, and they can air it to the endocrinologist they wish to ask to, while we are going through several of the questions listed in the chat questionnaire, and from which we will screen some questions and we'll ask the endocrinologist while we open the floor for live questions to Dr. Khadija and Dr. Kavita. You can unmute yourself and please ask the questions while we screen through the questions listed in the chat. I noticed Dr. Kavita has answered several of the questions raised. If you would want to live ask the questions, the floor is open. While Dr. Ramara, you can help me screen the questions and we can ask.
Hi, Dr. Vanitha, can I ask a question?
Yeah, let me introduce Dr. Mohammed Salman. He would be the Bahrain perspective of the CMEs that we would be having henceforth. He will bring us the Bahrain specialist to complement the IAP didactic sessions in the subsequent webinars. Dr. Mohammed Salman, you can ask the question.
Yeah, thank you, Dr. Vanitha, and thank you for all the speaker. And I think this is the cooperation between the IMH and the IAB. It will be a good initiative for Bahrain in terms of the learning, CME, and also later maybe in research also. My question regarding the obesity, with all the measure and the treatment and the modalities of the management, the WHO expecting that within the next coming 10 years, the rate of obesity will be doubled among the children. So what we are missing in the management to decrease this rate in the future?
The question is to Dr. Kavita. Dr. Mohammed Salman is asking, what is from your opinion, what would be something that would be the integral part of intervention to prevent the fearful statistics that has been projected for the next 10 years? Dr. Kavita, but from your opinion, where do you see the future and what do you think the interventions would be impactful for the future of containing this epidemic? Dr. Kavita Bhatt, after which Dr. Khadija will air her perspective.
Yeah.
I think Dr. Kavita is muted.
They also have some surveillance.
Thank you, Dr. Kavita. Please go ahead.
Yeah. Could you repeat the question once again, please?
Yeah, Dr. Salman was talking about the projected statistics for the next 10 years. Seems like the epidemic will almost double up. We have already brought the focus to the interventions that will help in containing this epidemic. From your opinion, what would be the strategy to not reach the fearful statistics that has been projected for the next 10 years in this epidemic?
From my strategy, I mean, as a clinician, because we need to be, one thing is, I think we need to get more involved in advocacy for bringing about policy changes. That is one thing. Second thing, at a clinical level, I think we need to promote the use of BMI chart as a tool in a big way, because in our clinical practices, often we miss out the insidious development of obesity. I think BMI chart as a useful tool should be promoted very widely, and that would be our small way of addressing this issue. And of course, policy changes and advocacy are also, but I think for clinicians, it's a little difficult to get involved in all that, but we can always support those who take such initiatives.
I think, yeah, it should be also come from higher authorities, in my opinion, because, you know, we can prevent such things. Like if you look at our society in Bahrain, you can see like there is a lot of promotion for fast food. Even for my kids, when I go with them, oh, we want to take the Happy Meal, there is a gift on it or whatsoever. But we don't promote a lot of like healthy snacks like vegetables and fruit. I think it should be from higher authorities in school and our society. Yeah, because it is a danger. You know, the last period when the COVID came, the obesity increased worldwide because just the movement, they sit down, they do everything online. We should encourage movement, do more things toward this just to prevent as a prevention for the disease. Should be something come from higher society, higher authorities, I think, as stakeholders also.
What the speaker do you think about the use of the technology? As I read to a new article mentioned that using the artificial intelligence can predict obesity in children 2 years in advance. So is this will be the future tools that we can predict obesity in children so we can focus more on the prevention?
Well, I think so, because AI nowadays can be in so many things. We can predict this, we can take steps earlier than we have the problem, it appears. Yeah, it would be a very good tool if we can predict things like obesity. And also, as Dr. Kavita says, the doctors themselves have to have high suspicions, like when they see the BMI jump more, or for children who have small for gestational age and their BMI is higher, to prevent these things, to refer them to, or to give them the advices. I mean, so many things can be done, because obesity nowadays is a disease, and the complications of the obesity is, we see them as in 3 years old, in 4 years old children. We see with fatty liver diseases, with hypercholesterolemia, with type 2 diabetes.
I hope that answers your question, Dr. Mohammed Salman.
Yes.
The discussion can revolve over this. Dr. Mohammed Salman is involved in integrating artificial intelligence in the management of obesity, and his questions were to highlight the use of artificial intelligence. As Dr. Khadija said, artificial intelligence these days are used to integrate it in very many ways, and of course in obesity also. So to summarize what Dr. Kavita highlighted, BMI is a good screening tool, and we should all be proactive in using it. That would be one message for the pediatric practice community. Second, she brought our focus to the IAP guideline, and IAP summarized pediatric obesity guidelines. And as pediatricians, we have a lot of guidance as to where we should be involved. And as Dr. Kavita emphasized, to get involved in advocacy and lifestyle changes, we can emphasize it in any way that we can, apart from our commitment to screen comorbidities, of course, is our role. We will have to integrate very many specialities where pediatric endocrinologists, thankfully, we have them to champion the cause of integrating the care. There should be one leader in a complex condition like this, and we have pediatric endocrinologists to integrate it all. Having said that, the importance of pediatric gastroenterologists, because liver disorders, the NAFLD happens to be one gross complication which can be avoided when we manage obesity well. And type 2 diabetes, the incidence of type 2 diabetes have scarily increasing, which coexist with pediatric obesity. And of course, orthopedic ailments, which are a burden because of pediatric obesity. There are a list of conditions Dr. Kavita talked about. It is indeed a complex disorder. As pediatricians, where we belong is in the screening and utilize whatever technology aid we can, like artificial intelligence in screening, in providing intervention. As they say, TLC is the mantra, total lifestyle change. How we can get involved, the HFS says the high fat, salt, sugar diet, we will have to, right from the inception, from the early childhood to adolescence, we will have to across the board change the total lifestyle, and that's where the base core of what we are talking about lies. We will screen a couple of questions. Dr. Bramara will highlight some of the questions so the leaders of the CME can take the questions. Dr. Bramara, can I? Yeah, Dr. Khadija.
I just want to add one thing when I say, well, we need some policies from higher authority, this will add, but the main thing also is the family. As I saw in one of the comments, yes, it comes from the family itself, the awareness for all, I mean, the family can be the one who control the healthy food, the screening times and others. But because the problem is a huge one, we need also more of policies. Like, you know, when the tax kept for the carbonated drinks, it's reduced, the purchase of these drinks is reduced. So such things can help. This is what I meant. I'm not saying that's the only thing.
Yeah, exactly. Dr. Kavita said, for clinicians to get involved may not be very many options in these arena, but as Dr. Khadija is saying, that's for the national policies to assist us in containing this epidemic. So the total lifestyle change, as we are clubbing it to 3 letters, TLC, may not be as easy as that. It is a family-centered effort. Everybody has to put in to provide the best option of intervention. As both the speakers agreed, that's where the whole intervention lies, where the pharmacotherapy and surgery would contribute only very little part of it. Can I now ask Dr. Bramara to ask some of the questions listed in the chat? Yeah, yours will come there. You can.
Yeah, I can see a lot of comments on, there are no questions, but a lot of comments on the importance of reduction of screen time, of increasing physical activity, of improving sleep time, and addressing poverty. If I can take this opportunity, I'll just have a comment on this. Yeah, it was a very informative session. I would say we're talking about lifestyle modification, and we as pediatricians are mainly involved in prevention. And I take this liberty because I'm a practitioner of yoga, and I strongly believe, and there are validated studies to show that practice of yoga, regular practice of yoga and its exercises will not only improve their physical well-being, it also improves their outlook towards life, the perception into what kinds of food they would like to eat. In fact, there's a study that shows regular practice of yoga changes the mindset. So instead of going on to reaching out for fast food, children and adults actually look out for fruits and vegetables. So if we're talking at grassroots level, primary prevention, I think this should be it. I see that there is some resistance towards yoga. People think it's something to do with religion. But like, we don't need to be French to eat French fries, or Chinese to be eating noodles. You know, I think we need to adopt and globalize wisdom that can be beneficial for the whole of mankind. So I would strongly propagate practice of yoga, not just for obesity prevention, but for a host of other things. And I see that IAP has already taken this step forward. And I see that you've already included this in school campaigns. That's a big applaud to IAP. Here in Bahrain, we have come up with, AMH has come up with a with a program, a community outreach program for schools. We call it the DDD, which is digital de-addiction, dietary habits, and dental hygiene, and posture. These are 4 things that we want to include and go out and reach out to school kids to make a difference in their lives and see how we can prevent the NCDs. Yeah. And apart from that, I don't see any specific questions. Thank you very much.
Thank you, Dr. Bramara, for screening the comments and the questions.
Dr. Vanitha,
Yeah.
I would like to make a comment here.
Thank you, Doctor. Please go ahead.
It's not a question actually, but what I feel is this saga of obesity starts and goes on. So the different medical specialties which are involved, right from adolescents, and that means the physician who is looking after, and handing her over to the obstetrician who actually has to take special care and look after the pregnancy better. And then once the baby is born, the neonatologist handing it over to the pediatrician, and then the pediatricians again handing it over to the physicians, the offspring. All this has to happen in a very systematic manner. Having said that, it is easier said than done, because the follow-up has to be very, very prompt and timely manner. But I feel this is required. There shouldn't be a break, because this obesity goes on. And if we do not do this systematic follow-up, then the morbidity will be even more and more. In place like Bahrain, where I feel the follow-up is better or better managed, I think this should be really thought of.
Dr. Khadija is championing that cause, and we notice it. And we have, with support from the national policies, as Dr. Khadija was highlighting, the national policies are translated to activity because the sheer size of the country, as well as policy adherence amongst the population, is good. Okay, to summarize, Dr. Kavita and Dr. Khadija, the 2 cases Dr. George started with, gave an overview of pediatric obesity as in the perspective of a pediatrician, how he would be involved in this complex disorder. We could sense the complexity of this disorder, and as pediatricians, we probably cannot be involved so much in advocacy in the office visit, but we got some hints as to, we know that AAP and IAP have strived to come up with specific guidelines, which takes the burden off pediatricians to wade over these complexities and to adhere to some simple concepts so that we contribute to avoid the comorbidities and the complications of obesity, and the gross statistics projected for the next 10 years, we would serve to avoid the complexities as we can put our effort as pediatricians. Dr. Bramara highlighted the involvement of physical activity as in yoga. She is one of the proponents of yoga in lifestyle change. This would, as our friends from India can appreciate the background of yoga and its benefits in very many things, would be a useful thing to adapt. And she quoted some validated studies for not just obesity, many NCDs as well. So as we could screen the comments and questions, we do not have any specific questions to ask. We would ask Dr. Khadija to ask for any specific discussion points to Dr. Kavita and Dr. Kavita's last comments before we come to the conclusion. Dr. Khadija, can you please
Dr. Kavita,
open the discussion?
First of all, just nice to meet you, and I'm looking forward for further cooperation between us. We want to do one conference. You visit us in Bahrain, and we'll do one day for pediatric endocrinology. I'll be very happy to see you in person.
Yes. We could collaborate on many things. I think that would be very, very nice. I'll keep in touch with you, Doctor.
Sure. Thank you. Thank you, Dr. Khadija. Dr. Khadija.
Bye-bye.
Dr. Brahmara, do you have any questions before we can?
No, I'm fine.
Yeah.
I think this collaboration should continue for the benefit of mankind, I would say. We'll extrapolate it. This is a small beginning, but all the very best. And congratulations to everyone involved in doing this.
Dr. Kavita, your closing comments, we will wind up. Dr. Kavita, what would you summarize this event?
I think the best part of it was meeting all of you and networking. I think that's the best part of the meeting. Apart from obesity, that's what, and I invite you all over to Bangalore, as well as to our center, Astor Hospitals in Bangalore. All of you, please do visit us. You're our guests.
Thank you, Dr. Kavita.
Yeah.
Dr. Ranjan, and I think Dr. Basuraj is still available. Dr. Basuraj, thank you for being available for the inauguration, and thank you on behalf of Dr. George Harrier. Thank you from American Mission Hospital. And Dr. Ranjan, can you please give your closing comments also before we wind up?
No, I'm very glad that this session went on as well as it did. Both the talks were very interesting and very informative. And this sort of gives me a feeling that this collaboration will be very helpful to each other and will go a long way. Thanks for everybody, starting from Dr. George Cherian and Dr. Vanita and all the attendees from Bahrain. We take great pride in thanking you and assuring you from the IAP side, all cooperation will be given for this venture to continue. Thank you. I will have to leave now. There's a meeting which I am supposed to attend, one of the election meetings, which I had mentioned to Dr. Vanita. But thanks a lot for everything. Thank you.
Thank you, Dr. Ranjan. As everybody is talking about, this is the small beginning. The next month, there will be recurrency in meets. The next month, it will be again the 4th Sunday of November. We will please stand by for the details. We are planning on a live session in Bahrain. Our friends from IAP will be visiting Bahrain, and we will be having a live session from Bahrain. We are to finalize the details, and we will be stand by for the details. We'll be airing the details soon. And thank you all for attending. Thank you one and all the participants and the IAP dignitaries, and big thanks to Dr. George for giving his encouraging words when we started. Thank you all and goodbye.